Welcome to the Jack Westin MCAT podcast with your host, Phil Hawkins.
And Azaii Muniz. Welcome, everyone. We are excited to have a new episode out today, and we're going to be talking about psychological disorders. So for those of you who are following us, we are going through the AAMC Psych outline, and we are in 7A. So we're going to be talking about the psych disorders. This will be a multi-podcast conversation regarding the psych disorders. There are so many. They're so interesting. While, you may not see as many of the questions about this as, for example, of like the behavior, different types of behavior modification and learning. It's a really interesting topic. And it's also something that, you guys are interested in becoming doctors, right? You're planning on going to medical school. This is the kind of things that you'll be talking about in medical school and the kinds of things you'll be talking about with patients. So we're really excited to get started. Phil, any thoughts before we dive right in?
No, I completely agree. Like this 7A is a monster. It's the biggest, hardest section of the psych outline. And so we're going to be spending, we've already spent like a couple of podcast episodes in it, like talking about personality, but now we're going into the psych disorders. There's a lot of them. It's really complex. There's a lot of things going on, but also I find students actually like to study it because it's actually related to medicine, like very clearly, like you will be diagnosing people with these disorders. You may have some disorders. You may start to recognize like, oh, these people I know, they have some disorders that I wasn't aware of. I feel like that happened to me all the time when I first started like realizing all of the disorders that were out there. I'm like, wait, I think I have like 3 of these. And so while it is very long and pretty complex, it's also really interesting as you start to learn kind of like what's going on with all of these things overall.
Yeah, I completely agree. Caveat, please don't go diagnosing people and telling them that they have a mental health disorder. You might get drop kicked.
Right.
But yeah, so we're really excited. So before we go into the actual disorders themselves, right, I think it's important to have a framework to kind of base our conversation off of. And so, it's important to think about, okay, what goes into the different types of psychological and psychiatric disorders, right? So there are 2 main models or approaches to how these disorders come about, right? And so the one that I think most people are probably familiar with is the biomedical approach, right? So this is focused on the physical manifestations and physical characteristics of these disorders and how they come about. So for example, talking about neurotransmitters in depression, right? Thinking about how antipsychotic medications work and what that tells us about the disorders that they treat. So the focus there, right, is on the physical, hence the name biomedical, right? So we have the biological component, but also in the context of medicine, clinical, what you're doing to treat it. Then there's the biopsychosocial approach. And as the name implies, it's going to take in a lot more than just the physical, right? So it's going to take in the social factors that play a role in the development of these disorders, thinking about how stress might play a role in the development of a disorder or bringing out a disorder that someone might have a higher disposition towards, right? So thinking about, okay, well, the environment that we're in, right, will create certain factors, certain influences that then go on to contribute to the development of a given disorder. And we'll actually talk about that a little bit, just kind of thinking, okay, well, in the context of this pandemic, right, what might be happening or what we might see more of.
Yeah.
So
that's such an interesting thing. So these are just like 2 ways of looking at psychological disorders, like the purely biological or the biological in context with the social. I think most people think like the biopsychosocial is the better one. But I mean, like, don't underestimate how powerful certain medications are for helping certain disorders. And like they're like the pure biological thing actually has some good effects there. Obviously it's nice to fold in the social stuff. Like in the real world, it can actually be kind of difficult to do that because like you might be talking about therapy and things like that. And a lot of that's really expensive. Turns out a lot of times for patients, it's easier to prescribe them a pill that they, go fill once and then they take every day, then have them like carve out, an hour of their day every week to go pay for a therapist. And so financially, in terms of time, it can sometimes be hard to approach things from a biopsychosocial approach, while sometimes it may actually be like the superior approach, depending upon like the actual disorders. But biomedical can be really successful as well.
Yeah. And I think that's also a really important point, right? So as we go through these disorders, thinking about how that's going to affect your future patients, your care, right? You're not expected to know what medications to prescribe or, for the purpose of the MCAT, right? That's beyond the scope. But you can start thinking about, okay, what might impact my ability to take care of a patient with some of these disorders, right? Even if you're not going to become a psychiatrist, even if you're not going to become, just go into mental health, that field of medicine, like you're still going to be working with patients who have psychological and psychiatric disorders. So just thinking about that, it's always interesting. It's always worth having in the back of our minds.
Yeah, I really like pointing that out, because even if you're like, you might think like, oh, if I'm in radiology, I don't have to deal with this, but like people with psychological disorders are actually more prone to getting into like injuries and things like that. And so like, just because you're not specializing in schizophrenia, it doesn't mean you'll never have to do an X-ray on a schizophrenic. And so like, that's something to definitely factor in. This isn't something just for people going into the psych field. I feel like all medical fields need to worry about this or think about this.
For sure. And then just kind of like we mentioned offhandedly, right? Just thinking about even something like this global pandemic and how that's going to influence the prevalence of disorders that we see, right? This is a collective trauma that has been experienced. And so, in this case, right, the biomedical approach won't have all of the answers, but it might have, like Phil was saying, some of the solutions. So thinking about, figuring out what folks might have, right, in response to, for example, the pandemic, we can think about how these disorders get classified and diagnosed. So there is a resource called the DSM-5. So I always have to have it written down because I will forget what it stands for otherwise. So the Diagnostic and Statistical Manual of Mental Disorders, right? And so currently on the 5th edition, this is a bit of a controversial resource out there. So it's the central resource for diagnosing psychological and psychiatric disorders, but it has a very intense history. So it has historically categorized things that we no longer consider mental disorders as mental disorders. It also has a lot of incomplete classifications. So for example, right, the way that disorders are classified now is when you read through it, and not that this is something that you'll necessarily want to sit down and just read through for fun, but it classifies a lot of disorders based on the severity of the disorder. It classifies them based off of timelines, right? And it's a little hard to say, okay, I have been experiencing this symptom for exactly, 73 days, right? So now it no longer classifies as X, it now can be classified as Y. So there's a lot of varied agreement on the DSM-5, but people still use it. Physicians still use it because it's there for a reason, right? The thing is, it's not the end all be all. And physicians will often include their own experience with patients. There's also the very real possibility that we are missing diagnoses, right? And there will be collections of symptoms that we do not currently consider, okay, this is a, mental health diagnosis that we can address, but in the future it might be. And so this resource is being, every so often it gets reevaluated and it is changed, it's edited. And so what we are talking about now may not apply in 25 years, right? In 15 years. So I think that's also what can make psychology and psychiatry really interesting, because you're comparing what you live with, the textbook definition with what might be. I'm trying really hard not to geek out about this.
Yeah.
But it's really interesting, controversial.
It's a very cutting edge like place, because like it's really hard. Like a lot of people are going to look like, well, if the DSM-5 is not as, or if the DSM is not as good and it's like missing stuff and things like that, then why do we use it? Why don't we have something better? But it's just because psych is hard to measure. It's hard to like, it's like does somebody have diabetes or not? We measure that off of what their glucose levels are. Does somebody have hyperkalemia? You measure that off of what their potassium levels are, right? Like, and so it's like really easy to measure these things, but a lot of psych stuff is hard to measure. And especially if somebody has had a psychological disorder all of their life, it's like they don't even know that like how they're experiencing how they are experiencing the world is strange, right? Or is different. And so it can be very hard to diagnose these. And so that's why the DSM-5 and like our understanding of psychological disorders is like changing over time. And as you mentioned, there's some diseases that like we don't consider diseases anymore. Like I'm sure on like some of the early versions, like homosexuality was in there, and like, okay, we don't consider that a disease anymore. But we also adding a lot of other ones. We also change the names of them, in part because we start to learn more about it, but sometimes in part just because we understand or because of how society has come to view something. And so, for example, multiple personalities disorder was on a previous version. We don't call it that anymore because people became aware of multiple personalities, but they became aware of it through like movies and depictions of things that weren't always like actually accurate. And so if we call it multiple personalities, people are going to conjure up this idea of this disease that's not actually how the disease works. And so we don't call it that anymore because like the populace has picked up that term and remade it into a different term. And okay, we can't use that. And so like that and like hypochondriac, we don't call it that anymore. Like that used to be a disorder, but we've changed the name to like not confuse people. And so it's like a really interesting thing. It's also really frustrating because I was in med school when the DSM-5 came out, the newest edition. And all of the physicians I worked with were like very annoyed because like, okay, I have to relearn all these criteria. I have to relearn new names for diseases. Certain diseases don't exist anymore. And certain diseases, new diseases have popped up. And so that sounds like kind of obnoxious. But I mean, if you're like if you want stuff that's like concrete and solved, cardiology. We understand how the heart works. We know exactly how it functions. The brain, it's a little bit messy. Like we don't have all the answers yet. And so our understanding of that is going to grow. And so because of that, like psych is not a solved field, but that also means that there's a lot of room for growth and like learning and expansion. And so that's one of the reasons that's pretty exciting overall.
Yeah, I had a professor who once said, and he's a psychiatrist. He said, if you're looking for certainty, psychiatry is not for you.
Right.
Truer words never spoken.
Right. So one of the interesting things that the AAMC will test is like on their outline, they have this idea of the rates of psychological disorders. And so they want you to know like the different rates of these. Now, you don't need to know like specifically what's the rate of this subtype of like this specific psychological disorder. But I do think it is important to have a general idea. I think psychological disorders are way more common than people realize. So if you look at like the general population, right? In any given year, in 1 year, 25% of the American population will experience or will have a psychological disorder. Now, some of those psychological disorders are like chronic and some of them are transient, like something that you just experienced like this. I had a really bad year and my wife divorced me and like I'm having a really hard time this year psychologically. And so these things don't always like stay with you forever. And so that 25% per year, like that can change, right? And like, who in the population has it. And so that's like 25% will experience a psychological disorder. That doesn't mean 25% is diagnosed. The rates of diagnosing psychological disorders is way lower, because there's still some stigma with psychological disorders where people don't want to go and get diagnosed with something because it kind of feels like a black mark against them. And that's just because of the field of psych is just kind of a strange one, right? Like, I don't think people feel guilty, like if I got the flu, or feel guilty if my blood pressure is too high, but people will feel guilty if they get diagnosed with depression. And so they'll feel like it's their fault and like they did something bad. And that's not that's just because there's some weird stigma with that. Stigma is also a psych term that we may talk about later. And so while 25% of a population will experience psychological disorders in a given year, it's only 46% of the population, according to JAMA, the Journal of the American Medical Association. So 46% of the population will experience a psychological, or will be diagnosed with a psychological disorder over their entire lifetime. Like in actuality, that's probably something closer to like 80% or like 90%, because every year, 25% of the population has a diagnosis or experiences it. They're not diagnosed. It's just so 46% of the entire population over a course of a lifetime will be diagnosed, but 25% of a specific population will have a psychological disorder. So the rates of the disorder and the rates of diagnoses are very different. It is probably worth knowing that the most common psychological disorder is the depression, like mood disorders. And so those are the highest, the most likely ones for people to experience.
Yeah. And I think going off of, like what you said, so you don't need to know exact percentages, right? Whenever possible. So I'll try and throw in some of the stuff that we talked about in class, just to kind of give you guys a perspective. Just know that when we do that, that's not because you need to know the exact percentages, but you do need to know, for example, like if you said, schizophrenia, a quarter of people have schizophrenia, would be like, no, that is not accurate, right? It is actually quite rare compared to some of the other ones. So just having a general understanding. And to your point of stigma, yes, there is so much stigma around mental health disorders, psychiatric disorders and illnesses. And I think even within healthcare providers, and hopefully our conversation, today will help show you like that doesn't have to be that way, right? A lot of physicians have very high rates of substance use, of depression. The American Medical Women's Association recently came out with this toolkit for medical students and providers about how to care for themselves, peers, and patients. And so what's really interesting is they talked about the prevalence of depression and suicidal ideations in medical students. And so what's really interesting is when people start medical school, their collective prevalence, so like just how likely they are to have depression, is comparable to the general population. But as they go through medical school, that actually increases. And so they quoted the American Medical Women's Association in their toolkit, quoted a paper from, I think it was like 2018, that noted it looked at medical students across both Western and non-Western countries. And the prevalence of suicidal ideations, right? So thinking about committing suicide ranged anywhere from 2% to greater than 50%, right? And so this is something that is seen even in, our future cohorts, future physicians. And so having these conversations, being able to say, okay, this exists, right? There's something we can do about it. It doesn't have to be this way. Mental health disorders don't have to go untreated, right? Is really important. And I just want to take a moment to recognize that there may be some of you that are listening to us, as Phil said, that have some of these diagnoses, right? And so, no one is ever forced to disclose. Also, there are folks who I know in our school actually have, and they've written pieces about it. And there's this new like online, it's not like a journal. It's like students have just written pieces about like their chronic illnesses. And it's actually really interesting and it's very enlightening. So, go out, look for those articles, those resources, if this is something that interests you. And if you just want to listen to the podcast and say, okay, this is enough for me for now, That's also okay. But hopefully our conversations are sparking people's interest, because it really is an interesting and important topic.
I feel like that loops back around to the biopsychosocial approach, because what's happening to people in med school is like you're put under like very difficult, like in a very difficult scenario, and competitive, and you can't go on vacation for a month to just hang out. And so the pressure and the level of responsibility skyrockets. I actually would be really interested to see that, because I bet we see that in the students studying the MCAT as well. So there's a good chance that you're kind of going through that. And that actually, relates back to our very first 6 or 7 episodes of the podcast, which were about how to make sure that studying for the MCAT and getting through med school was something that was sustainable for you. So like having like good practices, like I know it sounds silly, but like exercising even just a little bit has huge impacts on depression. And I know we talked about that a lot when we had the podcast about stress. But I think that it's really important to understand these things and don't feel guilty if you're having a hard time, but like, having an idea of how to like deal with this and not just ignoring it, which is how like the normal, like, with the stigma, like everyone just pretends like I'll just try to be happier and that'll fix it. Like, no, like there's things going on here. And so, I just want to like echo, if anyone out there is having a hard time, like reach out, don't try to like hide it, but like, talk to people, resources, treat it like high blood pressure, right? It's not something to be like, oh my gosh, like I can't talk about this. There's so much like shame in that. And so that's a really important thing. And not just for you guys personally, but when you guys become physicians, you need to echo that to your patients as well, and make sure that they know, like, don't feel like ashamed of this. And this is something that, would be helpful to talk about with people and maybe help educate other people, because that's one of the biggest problems in the psych field, just kind of overall, is just how it's not even the disorders, although some of them are very severe, but like how they are perceived is a problem as well.
Yeah. And I love that you said, that transfers over to your treatment of patients. So I think I've said this like before. So folks probably know or may not know that I took a year off of medical school because of like health reasons. And so when I was, I was very hard on myself during that time. I was like, I should have been able to like stay in school and like all of these other things. Mom was like, and she said this and it has never left me. And I think that's also why I've changed how I am in medical school now. She said, would you ever talk to your patient like that? Would you ever try and hold them to the standard that you're holding yourself? Granted, she said this in like very sassy Spanish.
Right.
It doesn't quite translate the same way. But the idea being that, you have to show yourself the same kindness as you would a patient. If a patient is ill, right? Are you going to tell them, oh, go to school and like try and study? No, you're going to say, work on getting better, right? Do whatever you need to do. If a patient comes to you and, is completely distraught from a mental health standpoint, you're not going to say, oh, deal with it, get over it, go through life, right? You're going to say, okay, how can we work on this? What can we do about it? So have that same approach with yourself, have that approach with your peers, right? So just like human kindness is so incredibly important. And yeah, just thinking about that, I just really want to make sure that folks understand that it's okay, right, to have disorders, but also like, you're going to be surrounded by people who have them. Some of your classmates might, some of your peers, family members.
So just that's such an interest. So I wasn't planning on talking about this at all, but like you brought up your own struggles and, this whole, like for the last like 10 minutes, we've been talking about like, be vocal and explain and talk about things. And so a lot of you guys know I left med school after the second year, and that was very difficult for me because you have like med students tend to make plans in like a 10-year chunk. Like I have my plan for the next decade. And then, I was struggling in med school because I didn't, I want to be more in education and educating people and like, a lot of what we're doing today. And so the pure bench work, pure clinical stuff, I was having a hard time with that. And just because it wasn't the sort of thing that I enjoy doing. And I felt frustrated because, I would diagnose a patient, kick them out the door, but I really just want to spend 3 hours explaining to them what's going on and how this works and how to treat it. So that was very difficult. So I went through a big funk for like a couple of years because I felt like a failure because I had this plan and I gave up on that. And really, I just like changed my focus because I understood myself better. But that's definitely something that I should have approached things better. And like, I could have like the ramp up of like, like treating myself better took years when in reality, like it shouldn't have taken that long if I just would have, spoken up a little bit more. But that's that rural Missouri farmer, just like buckle down, don't talk about things. Feelings are silly. And that's not how things should be. But okay. I feel like we've.
Yeah. Thank you for sharing that. Hopefully, that resonates with some folks as well. So on that note, right, just we can start bringing up some of the psych disorders that you might hear, that you will hear us talk about, that you might see on the MCAT, right? So there are quite a few. It's a pretty long list. The MCAT doesn't cover all of the different types, but some of the ones that you'll see, right, are going to be anxiety. And that's the one that we're going to talk about in the rest of this podcast in particular. You'll see things like OCD. You'll see trauma and stressor related disorders, mood disorders. So thinking about depression and bipolar, the different types of bipolar, the psychotic disorders, so schizophrenia and related disorders and diseases. You'll hear us talk about dissociative. So when, Phil was saying, oh, we no longer call it multiple personality disorder, right? Dissociative identity disorder. So it now falls into this dissociative category, the personality disorders, which I think might be Phil's favorite. So all of these, are different classifications, different types of psych disorders that we're going to talk about. But yeah, why don't we just dive right in?
Yeah. I feel like this preamble of like talking about how to diagnose and how we go into this stuff, that like we went way longer into that than we had planned, but it's just because it's like a perspective is super important.
Listen to this on 2-speed.
Yes. Yeah, exactly. And so we're going to start jumping into like, we're going to spend like the rest of this session and the next several just talking through these disorders at the level that you're going to need to know them for the MCAT. And so the first of these categories is the anxiety disorders. And so within this, there are several subtypes. Some of the big ones you need to know, we're going to hit those. So I think one of the more interesting ones is like generalized anxiety disorder. And I want to compare that and contrast it to panic disorders, because they're like a lot of times people think anxiety is all just anxiety, but there's a difference. There's like, several subtypes of anxiety disorders. So I think let's start with the panic, because I think most people are familiar with like panic attacks, which is what this is, where most of the time you're fine. And then all of a sudden you have this attack where this intense sense of anxiety, a sense of impending doom is actually one of the like diagnostic criteria, which sounds like one of the weirdest like actual symptoms to diagnose them or to discuss with a patient. And so a lot of times patients feel like they're dying and think that they're dying, and they're going through this like really extreme anxiety that is it's not like purely rational. Like they may know that they're fine, but they can't stop this feeling of intense, experiences here. And there's a lot of interplay between this and biology. A lot of times when people have panic attacks, they start to hyperventilate. Note that when you hyperventilate, you push out more carbon dioxide, which makes your blood becomes more alkaline, which actually can exacerbate and make your panic worse. That's always why we have patients like breathe into a paper bag and like they're breathing out the CO2 and they breathe it back in, which makes their blood back a little bit more acidic, which fixes some emotional stuff, which is super interesting. I love like understanding how chemistry and like breathing and like how you experience the world, those things are all actually related. Because like that's like a respiratory thing. Like we're trying to stick into the psychological disorders, but those panic disorders are like these really extreme attacks. The other side of that is the generalized anxiety disorder, which is when you're just generally anxious, like people who are worried about different things, kind of like chronically. And you may know some people like this. Like I know some people like this that are like, anytime they hear anything in the news, immediately it gets spun in their head to like worst case scenario, like the worst thing that could happen. And like they're constantly worried and anxious about all of these things. And that can lead to a lot. Depending on how severe that is, that can lead to people like staying away from media and, like becoming like a hermit, because they're like, the more they learn, the more afraid they are, or it may go in the opposite direction where they feel like I need to learn everything. And so then you get some like obsessions and issues there as well. But it's important to know the difference between those, the panic disorders and the generalized anxiety disorders, ones they like most of the time find, but these like acute, very extreme attacks versus just kind of this general pervasive anxiety that just permeates everything in your life.
Yeah. And just to add a little bit to that, right? So another way to think about this, or something that might help folks that I think I found helpful. So generalized anxiety, right? This is going to span multiple domains and it's going to affect different areas of someone's life, like Phil said. With a panic disorder, right? These are unprovoked. This is not that, that it's coming, right? You might get to know yourself very well and then realize when you have one onsetting, right? But it's not that, oh, I know that at 5 a.m. I'm going to have a panic attack, right? It's also something that, and I think I've seen the MCAT test it this way. It's also something that can actually mimic a heart attack. So people might show up to the emergency room thinking that they're having a heart attack and it's a panic attack. And so hopefully that puts into perspective how intense these can be, right? This might stop, this will basically just stop you in your tracks, right? Whereas generalized anxiety, right? You can have very severe moments, but it can also just be like a very chronic, chronic ongoing. So I think that's something that having something that you associate with each of these can be really helpful. Just making sure that you can keep them separate. And that's not to say that someone can't have both, right? This is where the whole, okay, our diagnoses of these are imperfect. There might be some overlap. There might be things that we're missing, et cetera. But that's just something to think about. Generalized anxiety is actually pretty common. The lifetime prevalence is actually about like 9%. And again, I'm basing these numbers off of our classes, so they may fluctuate and whatnot. You do not need to know the exact numbers, but you do need to recognize that it's actually pretty common. It's actually more common in women than men. I think it's like a 2-to-1 with generalized anxiety disorder.
I wonder just like subconscious, like I wonder if that might be like diagnosed as well, because men are way less likely to talk to physicians about psychological issues.
Yes. So that is something that I've definitely, and we've had conversations about this, and we don't know, right, how much of this is provider bias, right? Just saying, oh, like women are just more anxious, right? And they come in with that, and then they're more likely to diagnose with an anxiety disorder versus, the patients that decide to present, right? Versus like the symptoms that they find are worth presenting for. So, the society and the social pressures on different genders. But yes, it's really interesting, something to think about. We're giving you guys a lot of things to think about. But that's, I think, Phil, you did like a fantastic job. This like generalized anxiety, right, versus panic disorder. There are also 2 other ones that we want to make sure that we contrast for you guys, compare and contrast, so that way you can keep them separate.
In case they both end up in like answer choices on test day, which is why we like do these like compare contrast, because these are similar, but you need to be able to pull these apart.
Exactly. So there's social anxiety disorder and agoraphobia. And so sometimes people will be like, okay, well, they don't want to go out. So what's the difference, right? So with social anxiety disorder, you're avoiding social interaction because of a fear of humiliation, embarrassment, right? Maybe, for example, some of the examples that I've seen given are, worried that people will start talking about you, or that you'll have like an accident, right? So for example, sorry, when I think of that, my brain is like going like this and my mouth is going like this. So, right. So somebody might be like eating out and just having like dinner with someone, and they're worried about how people are going to, perceive them like eating, if they're going to like spill something on themselves, if they're going to like make a giant mess or like trip and fall. So this is the social interaction component is what's really important. For agoraphobia, it's a little different. So, they're still going to generally avoid like going out, but the reason is different. So here it's a fear of, it might be open spaces, of public transportation, of crowds, of standing in line. The idea here being you might not have a route of escape. And so whereas in one, it's, more embarrassment, humiliation, and like that concern with respect to the social interactions and your interactions with other people. Here it's, I may not have a way of getting out if something goes wrong, whether that is, right, an intense humiliation or something else. So those 2 are similar but distinct, right? So for one, the name helps you a lot. So it's that social component. And in other, think of spaces, right? So the space and escape component.
Yeah, this is something that's really interesting, because very often, I just want to be clear, when we talk about like social anxiety, that's not people who like, I'm, like I probably don't want to eat spaghetti on this date because I might get like, it's kind of messy. So I'm not going to do that. Like, that's not social anxiety disorder. Social anxiety disorder is when those worries about interactions become so extreme that like you stop, and it changes the way that you interact with the world. So you stay inside, you don't go out, you would never go to a concert, you would never go, to a bar to hang out or like go meet up with friends. Like you kind of have this anxiety with component because these are under the subset of anxiety disorders. And so that's a really, really important thing. A part of me, like this is where my brain goes with a lot of these, is I wonder where the origin is. And so like the biological evolutionary basis, like obviously we as humans are very social creatures, and we definitely experience like shame if we like do something that everyone else would perceive as bad, which is one of the reasons that we like function as society, right? So even if you want to like steal something, like I'm not going to, because people will label me a thief and things like that. But we'll talk about stigmas and labeling and deviance and stuff later. But there's something there. There's also, I think, maybe a deeper biological thing with like being protected. Like people like being like animals, creatures like feeling like they're protected. And so if you look at things like squirrels or mice, like they don't just like run around in open fields. Like there's been some evolutionary pressures there to like stick near trees, stick near places where they can burrow, places where you can hide. And so it's like really interesting whenever I see a rabbit, whenever I like go for a walk, I'm like, okay, that creature kind of has agoraphobia like built into it. And so I wonder if there is maybe some evolutionary basis that this was important in some early mammals, and maybe it spikes in certain humans, like that gene, those genes and the stuff related to it become more active. And so, just to point out that these are not like, this might be like a biological thing. This might be a genetic thing. It doesn't have to be like a problem with you. And so understanding that better is interesting. But I always try to think of like, okay, why would these exist? Like, what are the underlying things related to it? So like social cues and social pressure versus like safety and not being exposed. Like those are kind of like two different things there.
Yeah. And I'm really glad that you brought up like impact and severity, because a lot of these disorders, like you can see like milder versions or characteristics in a lot of people, right? But it's not impairing their ability to interact with the world. It's not impacting their ability to interact with the world. They're not changing what they do based off of those experiences. So in that case, that wouldn't be classified as these disorders. Whereas, if it's impacted, like with panic disorder, right? Like you might avoid situations because you're afraid of a panic attack. So that's just like something to keep in mind. So I'm really glad that you brought that up.
Yeah. It's really interesting. I don't like to name names unless people have like come out as like, a proponent of like discussing a certain disorder. But there's some very interesting people that have had very successful careers that they've had to shut down because of these things. In my mind, I know there's a couple of performers that would, like were making millions of dollars performing stuff, but then every time they go on stage, they would have these attacks of anxiety related to like the crowd and like, the big openness and like the pressure there. And so like there's some people that like have these careers that most people would dream of, and then they just quit. And it's really hard for, a lot of people to understand like, okay, you are making millions of dollars a year. Why did you quit? Like you could just work for another 3 months and make $6 million. Like why did you stop? And like, well, there's something, they feel like they're dying going out on stage, like panic attacks, like heart attacks. And so understanding that is important. I feel like we jumped a little bit because we did talk about agoraphobia, but I want to talk about just like phobias overall. So phobias are these intense, irrational fears that people have, and so they are the things that like I know like this thing is not going to hurt me, but I still am very afraid that it will. And so there's some very interesting like things with this. And this could be like certain objects, like a fear of like cotton balls or a fear of rabbits or a fear of people or certain people, or it could even be like fears of situations, right? So anytime you have this like intense, irrational fear, and it's irrational, that points to a phobia. Just a side note, those of you guys who are like looking at phobias. I know emotion was a couple of episodes ago in the podcast, but like thinking about how that relates to like the Schachter Singer and the James Lang and this, like, I know it's not rational, but I'm still experiencing the fear. It's kind of an interesting thing there. And that would be a good way for the MCAT to bring a couple of topics together.
Yeah. And I say this like because I'm a very transparent person. When I was younger, I had the worst phobia of frogs. Don't ask me why. I knew it was irrational. If I saw a frog, I dipped. Like there were times I would see one, I would scream. It was bad.
Right.
It was bad. I remember I was once giving someone a hug and I saw one behind them and I jumped and they were like taller than me. So I went right into their chin.
Right.
So I feel bad. But yeah, so these, I mean, in that case, like it actually really did impact my what I did and
right.
What I saw and where I went. But yeah, and it's like it's not that you don't know that it's irrational. Like I had every understanding in the world that it was the most irrational thing. Like the frog isn't going to, kill me or anything. I guess if you had a poisonous one, okay.
Right.
But these, and I laugh and smile about this now, right? Because it's like, it's no longer a severe issue in my life. Still don't like frogs, right? But I'm not gonna like run away from one anymore. But it's just these, I know we talked a lot during this podcast. I suspect we don't normally actually keep track of time very well, but I suspect this might be our longest one yet.
Yeah, it might be.
Yeah, but stick with us. These are fun topics to talk about. Listen to us on 2-Speed. We're okay with that. And feel free to share whatever experiences you feel comfortable sharing with us about these. We'd love to hear. We'd love to engage with you guys. That's something that's really important to us. But thank you for stopping by.
Yeah, I'm really excited about the next several episodes as we dive more into these, like some very strange disorders out there, like disorders where people lie because they want people to think that they're sick, and like schizophrenia and like a bunch of like very crazy, interesting stuff. And we're just kind of scratching the surface by getting through the anxiety stuff. So we have a lot left to come.